name's Gary Ritter. I have the great privilege, actually, of serving as the Dean of the School of Education here at St. Louis University. And I'm thrilled to be introducing the second of our 3 panels in our webinar series, 1 year out, before, during, and after COVID. This is sponsored by the School of Education, also sponsored by the Research Institute here at St. Louis University. This session, session 2, is entitled Learning from Disruption, Innovating and Improving Due to the Pandemic. And we have an all-star panel. And to get moving right away, I won't take any additional time, and I'll hand it over to my colleague and friend, Dr. Art McCoy, who is a research fellow at both the research, or a distinguished fellow, pardon me, Dr. McCoy, the Research Institute and the School of Education. And we're thrilled that Dr. McCoy is on our team here at St. Louis University. And I'll hand it over to you.
Thank you so much. It's a pleasure to be with you, Dr. Ritter, and everyone. It's great to see you, and happy end of an academic year for those of us that are just completing our academic years. As you know, it's been a historic school year and academic year for education and for society. We have made it through a full school year in the middle of a pandemic, and there are many positive things from the pandemic. So we really are here to focus not on the COVID crazy, as I call it, but more so how disruption can help us innovate education. And we have with us experts who have helped us throughout this pandemic and who've been at the forefront for leadership. You're going to get to hear from each of them. They're going to give a 5 to 6 minute presentation, up to 6 minute presentation, some with PowerPoint, some without, to talk us through first their roles, who are they, their organization, and really some secrets to success and ways to innovate and improve our next school year or academic year, even still during the pandemic. And so I'm going to introduce each of them in the order that they're going to speak. First, we'll have Dr. Rachel Cherny, MD, Professor of Pediatric Emergency Medicine in the School of Medicine at St. Louis University, and the Medical Director of the Disaster Preparedness SSM Cardinal Glennon Children's Hospital. She also served on the task force for the reopening of our education schools, as well as society, the task force with Dr. Garza. And she's been a great friend in many research efforts with the CDC, one of which I'm included in right now as we speak as a school system. The second speaker is Dr. Rhonda Ballou. She is a PhD and chair of the Department of Health Management and Policy for the College of and Social Justice at St. Louis University. Dr. Ballou is a policy expert nationally, and she, of course, will give great insights for local and regional efforts, as well as actions that we should take as education leaders and beyond. And then last, we have with us a dear friend, Dr. Gwendolyn Diggs, who's the Vice President of the Urban League of Metropolitan St. Louis. She oversees many programs, including Head Start and Early Start, and she has led cutting edge research, I would call it, for an emerging practice in parent-child interaction therapy, as well as had many services that's been provided to help with the pandemic. She will talk about the ways that her organization can support your school systems and the community at large, but also some emerging innovative practices and advice. And so with that awesome panel, I really want to just simply set the stage very briefly with the time remaining as we begin, and seeing that some names are still rolling in who registered. I want to set the framework. First, after about 30 minutes of presentation, 6 minutes each, then we're going to have a discussion. That discussion will be free-flowing to have follow-up questions and follow-up discussions of points that may have been mentioned that I might tease out. As the entire presentation is going, I want to urge all of the participants to please chat in the chat box any questions, any comments, anything that you may wish to know more about, hear more about, or ask a question about. We want to hear from you. I see that we have our first chat from Dr. Ritter, and I also would love to see chats from everyone to come to everyone. Actually, you can send it to all, or you can send it to just the panelists, because we want this to be interactive. All right, having said that, I'm going to take the liberty of really quickly showing one framework before we get this going with Dr. Cherny first. I want to first share the framework that prompted this session and webinar. And I want to state something that is becoming a factual reality. I shared this and presented this as early as May 2020, and I'm sharing it again now. What I've defined as my framework for this situation in this period that we're in, this era. I call BC, like before Common Era, before Christ, before COVID, and that's March 2020 or before. Of course, that time is never coming back, just like BC will never come back again, and many of us believe that things will never be exactly the same as that period. Then you have afterwards at the end, AC. That's the period of after COVID is no longer a threat to our life or a threat to our way of life. That's the future. And I've made the approximate estimation after becoming a certified contact tracer through Johns Hopkins in as early as May 2020, that would take about until August 2022, and it'd be about the 2022-2023 academic year, where we will be in an AC reality, not after Christ or after Common Era, but after COVID is no longer a threat to our way of life. And as we see, we're going to hear first from our MD, who will talk about vaccination rates and methods and procedures and percentages of us, adults being vaccinated and so forth, and whether that's a solution or a temporary solution or long-term and so forth. And we'll add more questions to kind of poke around with these dates. But I know in one of my dinners last night with the head of CDC at a function, she was pretty clear, even though she didn't wear a mask at the function, she had it in her pocket. She said, we're about a year away from being in the clear from all of this, which puts us exactly at 2022, June 2022. So where does that put us right now, in between now and then? Well, that's a period that I call the present, and that's DC, not District of Columbia, but living during COVID. And during COVID, we've had to experience a lot. We've innovated a lot. We've made a lot of things occur to make a way out of no way to continue business and to continue learning and to continue society. There are many residuals from mental health to employment to educational, quote unquote, slides. Some call it education loss and more. What we want to talk about is how to innovate, and especially as we move forward into the summer session and the next school year, how to be successful in schooling and to innovate, and what practices should we continue and expect to see in the next days and weeks to come. All right, so having set that framework, I look forward to seeing you chat and put questions and comments as the presenters present. And let's start off with our first awesome speaker, Dr. Rachel Cherny. The floor is yours.
Get off mute. Can everyone see my screen? All right. So thank you. As I said, I'm Dr. Rachel Cherny. I'm a pediatric emergency physician and also focus on disaster preparedness. I wanted to go over some of the science that plays into our schools and our reopening, what we know. I think one of the most important things as we look towards the fall, the next school year, is that the science of COVID has been changing, and the levels in our community, et cetera, at such a rapid pace that trying to truly predict exactly what we are and are not going to need to do by the time August, September rolls around is still a tricky process. But I wanted to catch up on some of the science, where we stand with kids. It's been an interesting process for us this last little bit. So basically, current CDC guidance as it stands with masking in particular, because I know that is a big question. The recommendations of the CDC right now is that masks should be worn by all unvaccinated people when indoors and are not a substitute for social distancing. It should be noted that in mid-March, the CDC updated guidance to reflect a minimum social distancing in classrooms to 3 feet, with the exception of middle and high school students, where 6 feet was recommended if transmission in the community is high. This did assume universal masking, and I will go over a couple of the studies that led to that decision-making. They also recommended that masks be worn by all unvaccinated people on school transportation, and that does include a federal order on school buses, because the question becomes, is a school bus public transportation? Yes. So those recommendations are what are currently in place and should be used for our planning if you're following the strict CDC guidance. Those, of course, all the CDC rules are trumped by any Department of Public Health, state or local guidance that is provided also. What do we know about kids and COVID spread? We know that kids are more commonly asymptomatic, which means, they don't have any symptoms, or they're more mildly ill than adults, but they're still infectious. We know that kids are less likely to have severe illness or die, but that we do have a higher risk of hospitalization, ICU admission for Black and Hispanic children, or for those with underlying medical conditions. We know that kids and teens may be less commonly infected than adults. There's still a lot of question out there about how much that is the biology, because there do seem to be some biological differences in how likely someone is to become infected versus exposure in the early stages of COVID. And of course, it takes a while for data to catch up with the current events. Children just weren't out in public. They weren't being exposed the same way as adults. They were home from school, et cetera. So that is still going on, but we do know that there seem to be lower rates of infection in household contacts in children, which does indicate some biological component to that. So current state of COVID in kids, this was updated as of May 27th by the AAP, who've been tracking the rates of COVID. So there have been just shy of 4 million US pediatric COVID cases reported thus far. That represents about 14% of all cases, whereas children represent about 24% of the population. Now, if you look on the right-hand side, you'll actually see this is the percentage of cases for each state. And our state of Missouri is the third one from the bottom. So we've only had about 11% of our cases have been in children. Now, the question is, are kids in Vermont, which is at the top of the list, getting infected more than kids in Missouri? A lot of this probably reflects how much testing we're doing. And so somewhere right along that middle line is about probably the accurate of what we're seeing. So kids do seem to be infected less, although they are tested less because of that asymptomatic rate. In general, there have been about 5,285 cases per 100,000 children. They represent about 1.3 to 3.2% of all hospitalizations. And if you look at the cases in kids themselves, of the kids who get infected, 0.1 to 1.9% of them will be hospitalized, with a mortality ranging between 0 and 0.03, depending on the state, versus 1.8 overall if you look at the entire population, including adults. Of note, what's more interesting, as I said, 14% of all cases have been from kids, but if you look in the last week, that's actually up to 24.3%. So the question, what's going on there? A lot of that, I think, has to do with the fact that the adults are immunized, the kids are not yet fully immunized, and some haven't had an opportunity to become immunized. And so we're seeing a larger percentage of our cases represented by our unimmunized population, be it kids or adults. This is another map that helps explain that. If you look, the darker line, that's kids, and the light blue one, that's adults. And you can see the proportion. The kids are following the same kind of trend that we see in adults, but they're just becoming a larger part of what we're seeing because of such a drop off in the adult cases as we've started our vaccination. And you can see once vaccination really opened up that second week of April, if you look from 2 weeks to 5 weeks out from there, where people are starting to get fully vaccinated, how much our cases have been continuing to drop off, which is good to see. Now, then we talk about social distancing. Again, I said the CDC had recommended that you could change to that 3 feet. And this is huge for schools because there's a big difference in how many kids you can fit at 3 feet apart versus 6 feet apart. So if you look, Polly Vandenberg et al., they did a study looking at the effectiveness of 3 feet versus 6 feet. And this was among students and staff. And what's interesting about this, so the blue and gray lines, those are adults, those are the staff, and the orange and yellow lines are the students. And each one of those two lines, one of them's 3 feet, one of them's 6 feet. And you can tell staff were more likely to become ill, which is something we've known for a while, but it didn't seem to vary whether or not they were 3 feet apart or 6 feet apart. Same thing for our children. This is another study. This was done fairly early on, looking at physical distancing. Now, this is in meters. So 1 meter is about 3 feet. And you can see that based on, these lines are based on the baseline risk of infection. So how much community transmission you've got. And you can see the biggest difference you get is going up to that 3 feet. And then you do get some more drop off up to 6 feet. And after that, there is still risk, but it is continuing to become lower, but not at a significant drop off. And that's where we get those numbers that we're looking at, that 3 to 6 feet. So additional studies that have been done. This is one of the studies that we participated here in St. Louis, and it was a partnership between the CDC and the state of Missouri, as well as between Washington University and St. Louis University. And basically we looked at 22 participating K through 12 schools that were implementing multiple COVID-19 mitigation strategies, and looked at the school-based secondary transmission. So we looked at 102 contacts, close contacts of 37 persons with COVID-19. Now this is just our pilot data we did in December. We continue to collect 12 additional weeks, and those data are still coming out. But among the 37 persons, we had 2 of our close contacts within the school setting who became COVID positive themselves and appeared to have been an in-school transmission. We had some of the schools that we used had what was called a modified quarantine. So with the modified quarantine, those students were allowed to remain in-person school masked, even if they were in a quarantine status. Neither of those 2 students were in the modified quarantine. So again, that was our 2-week pilot study, looking at our and that sums that up. 42 of those close contacts were in the modified quarantine group versus the other 60 who were in you had to stay home quarantine. So of the 42 contacts who were allowed to do modified quarantine, about 30 of them were interviewed, 21 were tested, and we had no positive results there. Looking at our overall data that we'll be reporting out and publicizing later, we had about 134 cases and 720 contacts with 8 transmission events from 7 of our cases, which is about 2%. So very low in-school transmission with masking and social distancing mitigation strategies in place. We did, of note, use saliva testing, which was significantly more popular among our parents, and they're still doing classroom measurements to look at room placement and the transmission that we saw. So in general, we didn't see any in-person school associated with substantial community transmission. And the school outbreaks tend to impact students and staff more than just the students, or sorry, the staff more than just the students, and are usually associated with absent or reduced mitigation strategies. So additional things that we have to support is the pandemic task force has an education subcommittee, which was put together to provide evidence-based standardized input to the educational community. It includes physicians from infectious disease, pediatric emergency medicine, and disaster preparedness, as well as Education Plus, and each main area hospital healthcare system in the St. Louis area. And work has been done there. As another example of some of the innovation that we've used to address this, my own school district, which is Lindbergh, had a reopening task force consisting of 67 parents, students, teachers, and administrators that began meeting last June to start talking about how to handle the year that we just ended, looking at communications, facilities, health and safety, human resources and childcare, meal services, transportation, teaching and learning, followed by a gating metrics committee to keep an eye on the actual transmission. And that's one of the unique ways that we used to really determine what those policies should be and made sure we got input from everyone in our community when making those plans. So some of the things we had to think about are the non-COVID impacted concerns of our community as well. Schools provide, of course, as you know, regular services that are potentially interrupted by COVID-19, including physicals, your regular immunizations, mental health care, and monitoring for any signs of child abuse. And those are all things that we are looking at to see what the impact has been and how we need to try and address these, particularly trying to catch up on our regular immunizations for our children before the fall, as well as encouraging those who are have access to the COVID vaccine to go ahead and get that as well. And that is what I had to present, and thank you.
Thank you so much. Great questions, great comments in the chat, as it was a great presentation in the midst of the questions and feedback. And we will have time for some Q&A after each of the presentations, and I have each of them listed, but thank you for your leadership and wonderful presentation And please do also share how we can maybe receive that presentation, if it can be made into a link into the item or to the chat box. So thank you. Next up, we have Dr. Rhonda Ballou. She's going to present and share many great things, including the social determinants of health and a policy vantage point as we prepare for a even better next academic year and even summer session. Dr. Ballou, the floor is yours.
Sorry, I was still on mute. Oops. All right, I already have that introduction, so I will just get right into my slides. Just a few comments about social determinants of health in general and how they played out during the pandemic and implications for the community and for schools. So, I'm talking to educators, so most folks know about the social determinants of health, but basically they're where you live, work, learn, and play. And social determinants of health actually account for up to 80% of healthcare outcomes. Aside from actual medical care that you receive, doesn't have the effect on life expectancy and morbidity and mortality that we think. So as we've all heard in many different forms and from many different news outlets about COVID, that certain communities, African-American communities, communities of color, were disproportionately affected by COVID morbidity and mortality, and continue to be disproportionately affected by access to COVID vaccination and vaccination uptake. And so I just wanted to make the point before we start that it's not new that these social determinants of health that when they are not in place or not optimal, cause disproportionate burden of health, mental and behavioral health conditions for those that are subject to kind of subpar structural social determinant structural conditions that make it hard to maintain a healthy lifestyle, right? So no opportunities for employment, the tax base that goes into the school system is low. There's not a lot of home ownership, limited transportation, food security issues like social support, exposure to gun violence and trauma, and perhaps an ability to access healthcare. All of these issues are predispose or create circumstances that cause the communities that live in these conditions, or individuals and families that live in these conditions, to share a disproportionate burden of health issues, diabetes, hypertension, anxiety, depression. And then COVID kind of played out in the same way, right? So it wasn't that there are certain groups that were disproportionately burdened by COVID because it was genetic. It was that, you didn't have the opportunity to social distance. You had to go to work. You were more likely to be a frontline worker. You were more likely to be in a service industry. So it was perhaps harder to get off of work and to go get a COVID test and get that earlier. So there are a number of things that the same factors that lead to disproportionate burden of other diseases that pre-existed COVID also exacerbated the COVID epidemic in certain communities. So when we're thinking about schools and COVID and social determinants of health, we have to think about addressing social determinants of health that have been plaguing certain communities, especially in St. Louis City and the region. When we talk about recovery post-COVID, right? I know Dr. McCoy said that we're in present COVID, but as we get to post-COVID, we need to think about all of these issues that we experienced pre-COVID and that were exacerbated during COVID. As I know, as everybody on here is for the most part an educator, right? We knew there was a digital divide, right? That there are certain young people and families that did not have access to internet, but that became a critical issue during COVID. Everybody had to stay home or stay home during certain parts of the day. So now we have a digital divide, and now it became critical that students are able to access the internet to not have even to fall farther behind in terms of education. In the previous discussion, the previous talk, there was a mention of school services, right? Many children get most of their meals during the day from school and get, their physicals and things. So the whole concept of food insecurity, that predated COVID. So the fact that students got their meals during school and that during COVID, they may not have gotten those meals. I know that there are many schools many school districts that set up programs so that students could still eat during COVID, but that's just exacerbated the food insecurity that predated COVID. So many of the things that we talk about and that were highlighted during COVID that affected school children and young people that are attend primary and secondary school also affected them before COVID and will continue to affect them after COVID if we don't kind of make some moves and start to take care of these issues. Some policies to consider in terms of really addressing COVID recovery and in schools is addressing the digital divide, right? What are some policies, right? There's I actually gave a link to an article. I'm happy to share this. There's Missouri, this is back from March. Missouri representative says requiring student broadband access and a report on that will help close the digital divide. So how do we actually start gathering data to see which students have access to internet or not in order to close the digital divide? And closing that digital divide and looking at policy proposals for closing the digital divide is important just in general for healthcare access, for school access. I mean, you're not going to do well in school if you're not healthy, right? So to get information on how do you get your COVID vaccine, where do you get it? When we were signing up for COVID vaccines, people were doing that online. Those that had internet access were getting COVID vaccines first, right? So how do you get the families vaccinated if they choose to and get the kids vaccinated? And when they're able to for those under 12, and how do you, not necessarily just enter the school system. This is something that I've been talking with other community-based organizations about, is that now, there's the push to go and to have equitable distribution of vaccination into the communities and into these families that populate the school system. However, there are other health issues and other social concerns, and perhaps sometimes some leeriness that the first time you're going to go into the communities and really show concern about health is related to the COVID vaccine. So I would also suggest that, in terms of trying to close that digital divide, that it's not just used for COVID or pandemics, but it's used for other information that could benefit the community, so that when you're actually going into the community and trying to get people to get vaccinated, that's not your first encounter with the different families. More about vaccinations. Again, there's been an overall decline in childhood vaccine coverage in school-age youth since since COVID-19. And some of the other issues I was asked to speak about is, how do you actually get staff and individuals who work in the school system to get vaccinated and to track that, right? So right now, adults and youth age 12 and up are able to get vaccinated. Those of us that have gotten vaccinated earlier in the year, I'm actually kind of going on the right column first. Those of us that have gotten vaccinated earlier in the year might need a booster by the end of this year. We're not sure, depending on what vaccine, Moderna or Pfizer, have been, that you received, you might need another booster. So it would become part of our annual vaccine series. So, in terms of the school system and requiring a vaccination, there are already different school systems that have different policies and different practices, I'd say, in requiring flu vaccination. So I would really think about looking at what has happened with flu vaccination policy in different school districts and look at best practices in terms of having your staff get the flu vaccination and see how you can kind of replicate or borrow those policies for encouraging COVID vaccination, and to really think about the legality and the ethics and the perceptions and the morale related to tracking COVID vaccination as flu vaccination has been tracked in some school jurisdictions. So I don't think that there's any particular answer to how would you actually manage getting your staff to have a COVID vaccine, but I think that there are other lessons learned from flu vaccination in different jurisdictions that can be applied to different school systems. But I would encourage really looking more at what's the culture of your school system and what's going on in the neighborhoods and the communities where your staff live and where they come from, and making sure that it's not, again, that it's not just all about the COVID vaccine, but there should be some overall employee wellness and overall health, and to make sure that there's overall concern for your family or for the families and the staff in your school district, and not just the vaccination. So I think it would be better to kind of sit in a whole wellness campaign for staff as opposed to just vaccination alone. Another thing I would monitor is the policy and availability of vaccination for kids under 12, which is not out yet, but that might change how social distancing and other aspects of how you open your schools. And I will say to that as the CDC has the 3 feet and 6 feet social distancing, 3 feet is not 3 feet and 6 feet is not 6 feet, meaning that depending on your airflow and how your buildings are structured and your air and the ventilation, that 3 feet is not always the same 3 feet if your air is stagnant and there's no airflow and there's not proper ventilation. So that kind of gets to my next slide, that in terms of how do you implement the CDC guidelines, and if you're trying to keep your young people 6 feet away or 3 feet away, what does that really mean in terms of, is your school building a little bit older? Is the ventilation not great? Do you have a nice, airy, roomy space? So all of those things need to be considered in terms of your room infrastructure. So I would encourage school systems to really maintain strong partnerships with public health entities, with the city and county public health entities, and also with those entities that provide social services, because your families and kids, you'll have those individuals that have been socially traumatized and have had job loss or other things during the pandemic, and will continue to need help even post-pandemic or even after. We are no longer threatened by the actual virus itself, but those social issues that were exacerbated during the pandemic will still need to be addressed, and unfortunately may manifest in your young people and how they're able to interact at school. You could also consider being a vaccine distributor, not just telling people to get vaccines. COVID, flu, other scheduled vaccines include parents and staff. I would also encourage just stronger and more partnerships, as demonstrated here with Dr. McCoy being a research fellow, to partner with academic institutions for evaluation for school-related health research. As you try to figure out, what do we do? How do we recover from COVID from a school systems perspective? How do we make sure we are addressing the student mental health, making sure we're protecting them from infectious disease and from COVID? How do we make sure that we're catching up on all of those essential or soft skills that the young people may have missed by not being mentored or being in space? How do we figure all of that out? And once you figure it out, you want to see what the best practices are, which means it has to be documented. So I think that there's a lot of opportunities for research and for partnerships, because there's going to have to be a lot of innovation next year in recovery. So I would definitely consider that. I'm sure that all of the educators on the call here will be doing some very innovative and perhaps also stressful, but really innovative things on behalf of their students and the students' families and their community. And you want to make sure that you document and evaluate what you've done so that you can share it and you can disseminate it. So I would really encourage some conversations with your local academic partners, even beyond schools of education. No offense, Dr. Ritter there, but some of it might be health related. So we could all partner together, the education and the health people, and really figure out how you take these new initiatives and really push them forward and document and manualize or whatever it is you need to do. Also consider looking at some of having the school system be members of some of the STL regional COVID task force that are charged with recovery, and to make sure the school system is focused on those. I'm going to actually talk about the last point and then get to the penultimate point on here. Think about school-based health centers. I know that we've had some really great successes with school-based health centers, and some infrastructure is needed, but that could definitely be a point of contact for vaccinations and for other health issues that could benefit the community and families. And last, I would say that to figure out how to really invest in the overall health and mental and physical well-being of your parents and your kids, so that by the time you want to, by the time you want to just say, I want you to go and I want you to have somebody stick a needle in you, right? That's not the first time you've engaged somebody about their health, right? So it's necessary now. And, everybody's, like I said, is talking about the equitable distribution of vaccines. And it's like, well, I hope that we're able to take the infrastructure that we've built to address the equitable distribution of vaccines to the best of our ability at this point. And we are going to take that and look to see how we can use this infrastructure and these partnerships to look at the equitable distribution of other things that we've never had the equitable distribution of. But just in terms of vaccines there, the narrative around vaccine hesitancy, which we found out wasn't true, especially among African Americans. And I know, Dr. McCoy, you're the superintendent of a predominantly African American school district, that it was mostly an access issue, right? It's not so much a victim blaming issue, it was getting the vaccines. And there's hesitancy across all demographics and all communities. But if you're still trying to overcome vaccine hesitancy, again, if you want to have, if you want to build trust in your community in general or in any community, vaccine's kind of a hot button topic. It would be great to actually start engaging families and students in an ongoing and a comprehensive way about their mental health and their social health and how they're doing. Are they exercising? I don't know why that's. Do they have food, so that when we need a COVID booster, that's not the first time you've engaged them? Do they have access to care? Do they need a social worker to go get insurance? Are they signed up for CHIP? So I just think taking more of a comprehensive approach about health and well-being in the families would make a better sell. And I'm not saying that folks are not doing it, but we could all do it a little bit more in our community, so that when you need to ask, encourage folks or at least educate folks about getting a vaccine, that you've already educated them about other aspects of their health. So
wow.
That is all I have.
It's beautiful. We definitely want access to your links, and that was power packed. Thank you, Dr. Ballou, because that was power packed. And so I'm going to highlight 3 key points that is a beautiful segue, but that needs to be reemphasized. First is the ecosystem that contributes to health and wellness, which is your social determinants of health. Look at equitable distribution. Secondly, your auditing of your facilities and more, because 3 feet is not 3 feet and 6 feet is not 6 feet if you don't have great ventilation. Great point. Thirdly, documentation is key, because everybody's doing something, but we want to document what you're doing so we know what works and doesn't work. That was a key point from Dr. Ballou. And then lastly, the 2 things she emphasized is the collaboration and partnership with nonprofits and organizations and health entities for specifically the health and the mental wellness of your students, staff, and stakeholders. So power packed. And so thank you for that great presentation.
I'm gonna have to see if you can come to other presentations, because you made me sound good.
Hey, that was
Hey.
as somebody who's doing this work, it's impressive to see a policy expert as yourself literally hit all the things in that short period of time that leaders and people who are in the trenches, they really need to think about it. So that was really good. Seriously, Dr. Ballou, thank you.
Thank you.
And so Dr. Gwendolyn Diggs, who is an incredible partner with the Urban League, who's done incredible mental health work, and is someone that you can partner with as a nonprofit agency to help get some of these services. It's a perfect segue to Dr. Diggs to speak, to share some of the cutting edge therapeutic work you've done and things that you are doing and ways that people may be able to partner with your organization to help through this next school year. The floor is yours, Dr. Diggs.
Thank you, Dr. McCoy. I do appreciate this opportunity to just share a little bit about my work and what I do here at the Urban League. But more importantly, the Urban League has over 55 different programs and services to help support the St. Louis community and the county. It's just an outstanding opportunity to be a part of the Urban League. What I was thinking about as others were talking is very important to meet the needs of individuals at the basic level. And that is what the Urban League does, meet those basic needs. And I'm sure everyone is aware of the food drives that we have conducted, serving over 100,000 individuals, raising money, over $4.4 million to make sure that we feed the community. And just being able to partner on the line of serving and putting that food into the cars. I know that there are people on this call that has done that, but being able to see the need firsthand and having that line move and flow with just multiple cars just coming in every time we have an event to just be able to feed their families. And I will share this, it doesn't matter what car you drive, I saw that. All types of cars came through that line looking for food. So when you're hungry, it doesn't matter what you're driving, or even if you are in a car at all, we were there to provide the food boxes and the resources for those families. So what the Urban League has done with partnering with other agencies is provide PPE consistently. Since day one, Mr. McMillan, the CEO of the Urban League, has been that outreach for many families. We've also created opportunities through Save Our Sons and Save Our Sisters to provide jobs. Never before in my life have I known the job situation to be as it is right now. So we are trying to meet those needs also. Again, those basic needs: employment, food, shelter. This is what we do at the Urban League. And also to provide an education for individuals. I have partnered with BJC, the Head Start and Early Head Start, partnered with BJC to provide financial literacy series. We do that every once a month on a Thursday from 1 to 2. We have the financial literacy series. We have one coming up this Thursday on how to get a loan. There are so many different pieces that we try to provide to help grow people up or support them in whatever the need is. So I could go on and on about the different things that we are doing at the Urban League as a whole with providing those resources and meeting those needs of our families from March, before March, I would say, up until this point. Just making sure that we are training, supporting, providing information, and I'm going to bring it back down a little bit to where I am in my position as Vice President of Head Start, Early Head Start. So when the pandemic hit for the first time, we were charged to go virtual. And how do you do that in an early childhood setting, going virtual with the little ones? We were able to do that. We were able to secure funding to provide technology for our families so that they had a tablet in front of those babies to continue their learning. We were able to also continue a program that I partnered with Dr. McCoy and Washington University to provide social emotional support. That was another key factor because in a pandemic, we miss the fact that there are other needs that are just as destitute or dire for making sure a person feels whole and taken care of. Being at home with your little one when you're used to being in a school setting and taking care of your business outside of having that child right there with you can be very stressful. And I know that we all know what that can look like. So with our partnership with Dr. McCoy, I was able to bring that into the Head Start space, and we provided parents with an opportunity to get that support, that emotional support through parent-child interaction therapy. And that is an opportunity for parents to work one-on-one with their child and a therapist to get the child to understand and the parent to understand how to build that relationship, even though the child may be acting out or the parent may be stressed out. This therapy was able to break down those barriers. And what meant so much to me was the testimonials of the families that went through this program. They said, you know, my child is no longer hitting and scratching and kicking at me, but I had to change my way of interacting with the child so that the child could be different. And it was such a powerful opportunity for our parents. Those that were not able to participate in the parent-child interaction therapy, they attended the Parenting Wisely online curriculum, which also was supported by Washington University. So there were multiple opportunities for our families to just take care of that social emotional well-being. But what I found during the pandemic and during this time is that we needed something for our teachers. We needed something for our staff. We were taking care of our families, but what about the staff that are on the front line every day, bringing in the kids that, you know, they wanted to serve, they had to have a reduced capacity. We went from 17 kids in the classroom to 10 kids in a classroom, adhering to all the CDC protocols for social distancing, mask wearing, sanitizing our space, temperature checks. We went through all of that to the point that I had to create a handbook, a COVID handbook for our parents and for our staff so that we would know what the protocol and the procedures were. So that in itself can be a little bit stressful for our teachers. So what we were able to do with our teachers is to work with SLU, staff member at SLU, to do breathing exercises with our staff. So we would do that 3 times a day at 9, 12, and 3:45, where a dedicated individual will come on and work with our staff with breathing exercises. We would also continue to work with Washington University with the parent-child interaction therapy, but we put another leg on it. We were able to get additional funding to do the teacher-child interaction therapy. So there's a wraparound service that we provide to our parents, our children, and our staff to be able to cope with the things that may be coming into the classroom that may have happened outside of the classroom. So our teachers are embedded into that practice currently. And it's all because of the support that we receive from our community partners that we are able to do this and to collaborate, that's that word again, collaborate with others in order to make sure that we are providing a whole package of services to our clients. And so I just want to say that we were thinking about vaccinations. We were able to host a vaccination drive for Head Start staff, which was very powerful to even just for me to be there and check in my own staff members to get vaccinated. That was powerful for me to have them to be a part of that. So there's just many opportunities that I try to do as the Vice President of Head Start to support the families, the children, and the staff. We are currently, again, working with the Waterford Reading Program. They are providing our little ones with a computer that is theirs to keep, internet services, all of this as a result of the COVID experience that we have. And that's over $1,000 worth of supplies, meaning, you know, the laptop, the internet, the materials, the training, and they get to keep all of that. It doesn't come back to Waterford or to the Head Start program. That's the child's to keep. So we are continuing to make sure that we are providing opportunities for our families and just reaching out by any means necessary to make sure that we are meeting those basic needs of our parents so that when we open back up to 17 per classroom, we have not missed a beat. That is my worry, if I have to say and be transparent, that is my worry, that we are continuing to educate our children so that when they step into the kindergarten classroom, they have all the skills and learning that they need to be successful. Even in the midst of a pandemic, we can't miss a beat because this is our most vulnerable age and population. And so, Dr. McCoy, I will stop talking and turn it back over to you. And there's, again, as I said, over 55 services that the Urban League provides. And within each one of those services, we continue to try to help others to thrive.
Thank you so much. Thank you so much. 55 services that the organization provides to support families. That's amazing. And so connect in, go to the website. And I had to say our Urban League of the Greater Metropolitan Area is the best in the country, award-winning. And I'm proud to be on its executive board and proud to work with you, Dr. Diggs, and with Michael McMillan. So we're talking from food to money to childcare and so forth. I'm going to hit a few questions that was asked, and I'm going to do a quick presentation to put a bow on some of what was shared. So let me say, first question was capacity. You mentioned the 17th. Is that the 17th of July or August in which you plan to go back to full capacity? And what was your capacity like in the last month or two, Dr. Diggs?
We are funded for 931 slots. So there is room continuing to grow. We are always enrolling, but the 17 is the number of kids per classroom with 2 adults. So each classroom has a teacher and a teacher assistant with 17 kids in each classroom. But because of COVID, we went to 10 kids per classroom with 2 adults.
Perfect, perfect. All right.
So when we open back up in the fall, which will be after Labor Day, we plan to be at 17. We are slowly increasing our numbers.
That's outstanding. Thank you for that. Thank you. Dr. Cherny, this is a question for you. When will we be allowed to sing again in choir? When will it be safe? And any suggestions as it pertains to that?
So, you know, there's a lot of nuance to that. Part of it depends on whether or not the group that's singing is vaccinated and how vaccinated. Part of it depends on where that group is singing. Are they in the basement in an unventilated space, or are they singing outside? What we know is the farther apart you can be, the better vaccinated you are, the closer you are to an outdoor environment, and the less you can contain what comes out of the various orifices of your body, the safer you are. So it depends on how closely you can meet that. My son, for example, in middle school did trumpet all year long, and they had a cover that they put over the end of their trumpets, and they stayed 6 feet apart. So there are ways of doing it, but it really depends on what kind of environment you're going to be in.
That's a very good point. Very good point. Does it matter whether, so here's the question. It was asked before, should 6 feet be used or 3 feet be used with the unvaccinated children? Any advice on that?
The 3 feet was across the board for students. So those recommendations were not based on vaccination status. And I anticipate they may change further as vaccination status changes amongst our children. So that 3 feet would apply across the board. Now you might want to think closer to that 6 feet if you're dealing with a very high risk activity, particularly in your middle and high schoolers. So that's when you think about things like singing and such.
Definitely, definitely. And last one for you that I think was asked, when can children start using the drinking fountains again? I like that question.
So the closest that the CDC comes to commenting on drinking fountains is in their discussion of large events. And they say, go ahead and use drinking fountains as long as you are cleaning them at least daily and ideally in between, heavy use. So I think drinking fountains are hopefully going to be on their way back in. Now, again, you need to think about, again, how many people are using them, what cleaning you can do, whether your other options. It's always safer to drink out of your own water bottle. So it's a combination of strategies.
Thank you, Dr. Cherny. Appreciate that. If Dr. Ballou wishes to comment on any of these questions, or Dr. Diggs, feel free to. Here was another question in the chat that I know, Dr. Ballou, you can make comment to. When you were talking about the partnerships with organizations and just with health in general, it says, well, how can they stay in touch with some of the work that you were sharing, or where can they go to stay informed or to help parents be informed on what is safe as far as policies are concerned, or staff as far as policies is concerned, what is safe and access?
I would say that the city and county board of health meetings are public, and there is a if you go on to the city or county public health websites, there are a number of listservs that you can sign up on. The St. Louis COVID regional response team focuses on social issues. And I mean, those are all good ways to just kind of keep up with what's going on with COVID and to ask questions. So there's a, monthly, well, bi-weekly, and now the frequency is becoming less for health department board meetings as the pandemic is getting a little bit better controlled. But those are public meetings that you're able to ask the respective directors of health. And so I think those are important to be on right now. They're on Zoom. And then, and you can identify resources from those organizations, but really just to kind of get an idea of what are the social and health issues among your families and what are their concerns, even to do some focus groups or some listening sessions with your parents to say, what are your health and social concerns in the community, and identify other community-based organizations that are trusted by the community, to see how you can partner to provide services or to connect services for your families.
Thank you so much. Thank you so much. All right, so I'm going to share a little bit of a few of the innovative things that I am aware of and kind of show a nexus between each of the speakers with what was shared. Let me start with this slide. So Dr. Gwen Diggs spoke about this. This is child-parent or parent-child interaction therapy. This is an actual testimonial from a parent, first name Tanya, last name not disclosed for the sake of identity. She said that she was having major control issues, behavior issues with her 4-year-old son, had no idea of what to do or who to turn to, and was literally pulling her hair out, yelling and constantly at her child, her son. He was biting, kicking, and screaming at the mom. Of course, the pandemic has caused this for a lot of people, and not just 4-year-olds, but even older people have been kicking, screaming, and biting. But nonetheless, and she goes on to say, once connected with Washington University and the studies, she met Ms. Gabby, which is the counselor in our school district, Jennings, but also a therapist as well for trained in PCIT. Gabby was wonderful. She is wonderful. I learned so much through her. I learned how to talk to my son differently, praising him more, making demands and having them done without feedback. There is no more talking back, biting, fighting, kicking, scratching. And I'm totally 100% grateful for the Urban League for introducing this to me. All right, so that was a testimonial from a real mom and a son during COVID in DC, where it continued even through teletherapy. So working through the computer screen on what I call 3 Bs at least, understanding the boundaries that you need to put in place for youth, understanding bonding techniques on how to rebond, and then understanding even borders, but more so having boundless connection, again, with the circumstance, your own attitude, your own anger, or your own frustrations, and then your child's. And that's true, not just for a parent and a child, but also a teacher and a child. Why do I emphasize this as an innovation? I emphasize this as an innovation because once we're at 90 to 100% or 120% capacity, again, in people, we have to realize that something just happened to us that was traumatic to most of us, 7 out of 10, if not 10 out of 10. And so we need to acknowledge the trauma that people have experienced. And this is one way to do it. Now, I want to just define what is trauma. Trauma is the following, according to the board that I serve on, Mental Health America, the first oldest mental health agency in the United States that does trauma policy and work throughout the country with resources. So that's another partnership to Dr. Ballou's point. A group you can partner with is Mental Health America for vignettes and webinars and tutorials on becoming trauma informed, but there are other people that you can partner with. This is their definition. Trauma is the response we have to experiencing or witnessing an event or a series of events that threatens our life, our safety, our personal integrity. Now I ask you, is that not what we've have just experienced, and possibly many are still experiencing an experience, a threat, an event that's a threat? Secondly, trauma is a serious issue that happens as a result of physical, sexual, emotional abuse, neglect, violence, war, loss, pandemics, disasters, and other emotionally harmful things. And trauma can cause permanent changes in the structure and chemical activities of a child's brain. Okay, so the fact that we are in DC, for me, means that the innovation that we must take away is this. Jennings School District was the first district in the county and city to resume. We started in April, and then we did summer school in July. Dr. Hicks Prophet is on the line as one of the participants. She ran a elementary through high school summer session using interventions as a pilot to document best practices. And then we started in August on the regularly scheduled time with about 60% capacity. What we learned was this: Maslow's hierarchy of needs, physiological, your life was at risk. You had a need for water, you had a need for food, you had need to breathe. George Floyd lost his life, and with the words, "I can't breathe," due to an external force of a knee on his neck, while others had internal forces of "I can't breathe" from society and systemic oppression that leads to depression and anxiety, as well as isolation from isolation and more. You had some abuse situations at all-time high. These are physiological issues as well as safety issues. The lack of being together was taxing love and belonging. That was the other B that I was trying to remember. So boundaries in the therapy, also bonding, and then B, number 3, belonging. Some group to belong to, family, kinship, so forth. That was taxed. People have a thriving need to belong and to be together, and then that affects our esteem, but it also affects who we are, self-actualization. Who am I? What is my purpose? Okay, so we know this is Bloom's taxonomy. We know this as Maslow's hierarchy of need. Now, next to this is Bloom's taxonomy, but you see it's upside down. It's upside down because the physiological and safety threat and the lack of belonging cause for students to ask the question, why do I need to even physically go to school, especially if my life is at threat? Why do I need to go now that school is back in session if I can do it online? Is it essential, or should I just go to work first and then do studying and assignments at 10 o'clock p.m.? I see Susan Kelch on the line, or I'm sorry, Karen, with the homework works in the home visits organization. So the question becomes, what do we know, and is it essential for the child to be present, or is the home safe? Is there an environment in the home where they can learn based off of Karen's work, where we know many times we go to the home and the home is not an environment for learning? All of those questions are evaluation questions. So that if a classroom teacher, like I see a few online, or if a classroom a curriculum coordinator, a school district coordinator is working on projects, the projects have to be more service-based learning oriented, more learning and earning oriented, and more active citizenry oriented, because the student now more than ever is asking the evaluation type questions, making judgments the whole time. So if you start off with comprehension, you may not see them show up to your school. That's the point. Bloom's taxonomy has been flipped on its head by virtue of Maslow's hierarchy of need, bringing these issues of belonging, safety, and physiology to the forefront of what counts as learning. So competency-based learning is essential. Mastery-based learning is essential. Hybrid situations are essential. Wellness frameworks are essential because trauma is real. And so you ultimately, in every lesson, in every class assignment, the 6 thinking hats are essential as we embrace the future in AC, but also DC, do education better. We have to educate as if our life, legacy, and liberty depends on it, because it does. And that means this, not just telling someone things to think about. That's the thinking hat for Blue. But how are you feeling today, even before you start the quote unquote academic assignment? And how did it make you feel to do this? If you did an assignment on, anything, race relations, food disparity, abuse, any of that. If you do an assignment with stories and vignettes, how does this make you feel? Because you're a human being that's gone through trauma. Let's make sure that we're being sensitive, self-aware biofeedback, to use a medical term of an emerging practice. Let's be creative. How can we do things differently? So literally using your physical room. So if you're doing the coordinate system and learning the Cartesian coordinate system, making your classroom into a coordinate system where they have to go to the right seat that represents that system, using their physical body kinesthetically to learn the actual abstract concepts. More so the judgment hat in Black. That judgment hat is more important now than ever, because Bloom's taxonomy is upside down and their students are already making judgments on, why am I doing this way? Why do I even need to be here? I could be making $16 an hour from Amazon and do this later. So this is what education looked like for a lot of our students during the pandemic. Learning and earning programs, high school credit and college credit on paid apprenticeships. Let me show you our kids. That's what they were doing, earning high school and college credit, getting paid also simultaneously, $15 to $25 an hour. In the pharmacies, learning and earning. Again, getting paid, learning how to be a pharmacy technician, being a pharmacist technician, getting college credit and high school credit. At the university, both at SLU and at UMSU, online virtually while they're virtual, doing the 1818 series at SLU and other things in labs, but even virtually. What about the younger kids? Tinkering, time to tinker. So learning through play. Play therapy is another thing that is called, because some people say, and therapists say, everybody needs therapy. And I mean everybody. So why not have some therapy through play? Play therapy, time to tinker. That is essential personalized learning. The Montessori method uses this to a great degree. So that's an important piece. The last things I'll say is project-based learning, where if there's a problem in your community, there's a problem on the street, a problem in the school, make the problem a project to talk about it, write about it, explain it. Tell me how you feel. What are your solutions? Go find a partner, a partnering agency like the Urban League or the United Way or someone else that can help you get their expertise, their support, their resources, and that becomes your third grade project. Or elections occurring, or things are needed in your city. Write your mayor, send them, create the perfect letter requesting whatever, more food pantries because you have food insecurity, you know friends who have it, so forth and so on. That's project-based learning for the academic landscape. The last things I'll say is that it was mentioned about health-based school clinics. So I'll go to our clinics. It was so important to utilize what was innovation in BC before COVID became something that was needed for desperation in DC during COVID. So Jennings has 2 school-based health clinics. One is the SPOT clinic. SPOT stands for Supporting Positive Opportunities with Teens. They handle our high schoolers. And then we have Myrtle Hilliard Davis, Care STL Health. And that clinic ultimately services our elementary students and middle school students. You see the clinic here? The clinic was open even in March and April at the beginning of the pandemic, and May and June, all the way to July and beyond. They did COVID testing. They did immunizations. They are now doing research on the testing that is occurring. I'm switching my page to now our district website. Hopefully that's seen. And so ultimately, this is the research that they're doing with Dr. Jason Newland and the SPOT Clinic with Ferguson, Florissant, Jennings, Normandy, Pattonville, and University City on SLAVA-based testing, rapid turnaround feedback within 24 hours, as well as other mitigations. We're doing drive-through vaccinations. And so one question was asked about when will vaccinations occur for younger kids. There's a vaccination that's occurring in Ferguson. That's a pull-up at an elementary school, Gibson Elementary School, on the 9th of June and the 28th of June. We have a drive-through vaccination for our students ages 12 and up in Jennings on July 11th. And again, continuing at our Care STL clinic. And then of course, we're part of this 2-year study with the CDC, the second study. And I'll briefly mention a few points again. Food service, that's important. Getting students engaged in giving food. This is BC pictures. These are BC pictures of students giving food. And this is a DC picture of a food line with students still giving food. When I copy and paste my presentation in the chat box, you can click on the picture and it will show you that happening in a video that I created of kids giving out 1 million pounds of food during the pandemic. The other points that I will close with before we get to some last minute discussions is this. So as part of the pilot that was done with the help of Mrs. Alexander, Stephanie Alexander, who I think is still on the line, as well as Dr. Prophet, we had contact tracing district-wide. We use this link still to this day where individuals, all adults and students, click on the link before they come into a building. Secondly, there were people to do checks of COVID checks upon the entrance of the door. There were machines to do checks. This is what I call a triple redundant screening system. And then the classroom teacher did checks in the classroom. Part of the research supported by Rachel Cherny, who's on the line, Dr. Jason Newland, and Dr. Rachel Olinger from WashU was immediately, this is before the first CDC study was commenced and finished. And this became one of the mitigation strategies that I think will continue in DC for the next school year. The physicians identified low-risk symptoms and high-risk symptoms for kids with COVID. So COVID testing for kids younger than 12 will take some time, according to CDC. Jennings is currently in the pilot for testing that St. Louis Children's Hospital is doing, open to the whole region, to give COVID vaccinations to 6-month-olds all the way up to 16-year-olds. That will take time to study before it becomes something that is determined to be available for younger kids than 12. But towards the symptoms, physicians have agreed that if a student or kid or child has a cough, difficulty breathing, loss of taste or smell, that is a high-risk symptom for COVID for a child. If a kid has the other symptoms, a fever of 100.4, that is a low-risk COVID symptom for a child, more than likely not COVID. And so there are other low-risk symptoms on the screen. So what do you do as a nurse, as a teacher, if you see a symptom? Because kids have runny noses just for the sake of having runny noses. Kids have body aches because they're growing up. Growing pains are defined from that. Kids have diarrhea, well, just because they have diarrhea. So nonetheless, the point is, that may not be COVID. So what do? We created this and shared it with counselors and nurses. And then Dr. Cherny did an actual study based off of mitigation strategies with real experiments after this framework was created as a pilot. I do believe that this is sound information. It will be perfected over time, but this is an innovation strategy that really teachers have to be more familiar with as you get more students and don't know who necessarily is vaccinated or not. All right, having said that, I'm gonna stop sharing my screen. I had to just get those points for some innovation that is essential as we go forward. I think that it is important to work with people like Dr. Eccles, people like Dr. Garza, people that are like Dr. Cherny, people that are like Dr. Ballou and Dr. Diggs, each of them, because one thing is certain, you cannot successfully do schooling alone. You must partner with the experts to get the best information in real time and the empowerment to succeed. All right, so having said that, I want to get to just a rapid round of questions in our 15 minutes remaining. And I did try to get all the questions that were posed. If there are any others from the group, please chat them in. The first question I would first really ask is, can you each, I'm going to start with this one, this is Bart, give us your 2 to 3 recommendations from a perspective of I'm a classroom teacher or I'm a school principal. What would be your recommendations for how to move forward most appropriately for summer school and or the school year to have some innovation and great success during COVID? What would be your recommendations?
I can start.
Please do.
I think it's very important to continue to get the message out. We can not only just say it one time, we have to repeat it and we have to practice it. We have to make sure that all the protocols are in place consistently. And it's very important for me in early Head Start. Head Start is to listen, to observe, and to see if there's a need of individual staff members, students, parents, and children. That's key. To be just aware of what the needs are for individuals. So again, I would just say continue to be vigilant on your procedures and your protocols and making sure that you're following all the safety precautions throughout the building, throughout the day. It's just very important. And what I try to practice too here is to send out a monthly reminder of where we are, the space in which we are living in, and to make sure that we're continually reminding everyone of their role and responsibility in this effort that we have in front of us.
Well said. Thank you, Dr. Diggs. Well said. Dr. Ballou and then Dr. Cherny, what key recommendations for moving forward successfully?
Sure. I had a high schooler up until a couple of weeks ago. She graduated high school, and I teach. Hey, woo, I did it.
Awesome. Congratulations.
Thank you. But I teach other younger adults and college age students, and I would say that that despite our very best efforts and some really innovative things that we've done, young people have they've missed a lot, and they've missed interactions, face-to-face interactions with those teachers and mentors that they rely on, that they get support from, and just to be cognizant of that next year. I mean, right now, even for college age students that I teach, we're redecorating our department so it looks nice. And I mean, so it's just to really, as Dr. McCoy, you talked about trauma, just to recognize that there's going to be a little bit extra healing that's needed for these students to kind of get them back to regain those losses, and not just math, but in those social interactions. I mean, because school is not just the academics, it's all of the social interactions and things and socio-emotional growth. And to make sure, they get a little bit of extra nurturing, and things are built to really focus on that will encourage their learning. And even, for our adult or 18 and older students that we have in college, we've seen some just emotional and mental health challenges this year, and that have caused difficulties in learning, and to really just be cognizant of those and help these young folks to create an environment where they can overcome that.
Very great point. Thank you for that. And to also know that you can't lead on empty. So if you as our staff member need mental health support, go for it, get it. There's nothing wrong with it. Taking mental moments and give it to your children too. Thank you, Dr. Ballou, for sharing that. Dr. Cherny.
Yeah, I think other than, has been said, following our CDC guidance, mitigating our risk as much as we can while trying to get our kids back to normal as much as possible. We know when we look at kids and disasters, and a pandemic is certainly qualified, that resilience in kids is very much linked to getting back to your normal routine. So the most we can get our kids to normal, the better. And I think looking at our educational strategies and how we can give kids control, where is that school project that can actually have a direct impact on their day-to-day life and make them feel like they're contributing to what's going on, that they have some control over what's going on around them. That's, because I think that's one of the things our kids have struggled with, is all of a sudden they just lost control over everything that they counted on in their life. And trying to give that back to them, I think, is really, really important for our children. And that's looks different for every family. It looks different for every school. It looks different for every kid. But I think, trying to just find that space for them is really important. And just also not to lose these partnerships we've put together. I focus on disaster management, and these school physician department public health relationships we've built, we can use these to make our community stronger and more resilient in the future, and protect our kids.
Well said. Well said. Let me say this, because you mentioned one of my buzzwords of normal. I've come to believe normal is a myth. And I say that because of this. Having been very closely connected to tracking the deaths of Black men for decades, I would give speeches nationally and internationally saying that a riddle, every 2 hours, one aspires. What am I? And the answer is not a parking meter, but a Black male. And that was before the pandemic. And so we forced uniforms in an all Black environment because not one Black male youth has been carelessly murdered with a tie on, And it goes to what do we value in society? And so I'm gonna get away from that sensitive topic for me, but nonetheless, and share how I used it in the pandemic. I told people, welcome home. Because now every 2 hours, the answer is not just the Black male. Every 2 hours, it was even every 1 hour, there was somebody white dying. And when somebody white died every 2 hours, society has said, oh, let's give $6 trillion towards infrastructure. So now you, Dr. Ballou, made a poignant comment that I had to echo, and I never usually echo people, but you said it well in another conversation, and that was, the systems were never designed to be equitable to begin with. Health systems, education systems, And now we find ourselves in a situation as leaders trying to force equity in systems that weren't designed for equitable access. Because every 2 hours, the answer is not a Black male, but the answer was a white male and anybody due to COVID. So now infrastructure bills, EAA, ERRA funding, all this money, and no plan in many cases. So now I just had to share that normal is a myth, because for some people who had multiple epidemics, there was no normality, there were ACEs. And now that there's a pandemic, there's no more normality. There's an attempt to get back to something that's just called healthy. And so now I hope that we reconstruct society like the Reconstructionist period, so that we can have a more healthy and equitable society for all. And that's near and dear to all of us. I know that's why we do what we do. So having said that, I know that Dr. Ritter has an important comment and question that he posed in the chat. Go ahead, Dr. Ritter.
Yeah, no, I'm not sure it's important, but I'll give it a quick reaction to what we should do to be ready. And I don't mind echoing and amplifying great ideas. So I'll echo and amplify. And also then I want to get into Ms. Henderson's question. But a couple of things. I think we don't want to go into the fall and lose the benefits of what we learned during this past 15 months. And just, we've said that before, but what are the innovations? What are ways we can reach kids differently? We're focusing on some of our language of twin pandemics. We're focusing on, we're willing to talk more. Now, whether we will walk the walk beyond talking the talk, that remains to be seen, but we're talking more about systematic racism and figuring out how to deal with it. We have more voices who seem to be entering the conversation. Now, will we continue? I think we don't want to lose that focus, just like we don't want to lose the innovation that we talked about. We want to not lose those two positive movements we've had. Regarding SEL, I wanted to think of social-emotional learning and the trauma students have faced. And I just harken back to the way we talked here at our Jesuit institution at the start of the pandemic, when we were reaching out to students and faculty and staff and families. The consistent language was show grace and compassion. We need to meet them with grace and compassion. Our faculty might not be ready. They might be suffering in ways we don't know. Our students are suffering in ways we don't know. We can't be hard-nosed. We must show grace and compassion and lead with those. Well, it seems like coming back, we should circle right back around to that. We should try to bring students back, welcome them back with grace and compassion. And finally, the last thing, and leading into Ms. Henderson's question, with regard to, there was a question, has a tally been taken? Are the children ready to go back to school in person? And I'm not sure exactly what you mean by a tally, but it's certainly a good question as to whether students are ready. There's lots of controversy around the extent to which we should give standardized tests to figure out where students are to try and get them ready. And we dipped into this topic 2 months ago with Commissioner Van Dieven, and Dr. McCoy talked about it in our last webinar. And I don't think there's anyone who would call for a draconian accountability at this point in time, but there have been very reasonable calls for doing our best to figure out where our students are so we can meet them there come fall, or better yet, come summer. So we need to come up with innovative strategies, whether it be intensive tutoring, whether it be some more individualized learning. We need to be thinking about additional strategies to meet kids where they are and try and catch them up from the learning that they were unable to benefit from over the past year. So, Dr. McCoy, thank you.
Well said, well said. Can you, Dr. Ritter, elaborate for a moment on the twindemics? Because you mentioned that great term, and I just want people to make sure they know what that is. Go ahead and just give a soundbite on that.
Sure, I think that the language I use, and I have heard twindemic, Dr. McCoy, Christy Huck from City Garden Montessori School gave a presentation, and she was the first person, I know many others before, she's the first person I heard refer to the twin pandemics of COVID-19 and systematic racism. And this was over a year ago that we talked about it. And again, I don't want to sound too optimistic. I know I obviously don't have the experiences everyone else has, and I don't even have enough backwards history to know, but I I will remain optimistic that the conversations we have had certainly have seemed to be more intentional, more genuine on trying to figure out how to battle systemic racism, in the past 12 months than in the prior 20 years, from my perspective. So I'll remain hopeful.
That's beautiful. I appreciate that. Let me share this. Thank you for the question. Thank you for the explanation. Since George Floyd's death, these things from my perspective appear to be two sides of the same coin. I coined this work that we're talking about right now as DIE. I don't call it DEI for of course, obvious reasons. I'll make it very, very obvious. Diversity, inclusion, and equity. It's DIE because we die if we don't do it. We die as a country, as we've seen in politics, and on January 6th, there were deaths, DIE. We die as a business, as a company, and we die as a community, and as children, and as citizens. Those are all C's, of course. We DIE if we don't acknowledge the strength and the diversity, the inclusion of all thoughts and people at the table, and the equity that's needed for a more just society. And so when you have a pandemic where people say, limit your liberty to lengthen your life by quarantining, and then while you're lengthening your life and limiting your liberty by being quarantined or isolated, you witness on TV a knee on a neck that literally chokes out the life of a person for more than 6 minutes. Then that was two sides of the same coin that said, if my life is so important in the world and in the world that the world is isolating to save this thing that we each have called life, and we see someone having it choked out of them, what can I do to risk my life a little bit more so that someone else may not have it purposely choked out? It's the same side of this. It's existentialism if we were teaching a philosophy class, but we're not. So the point is, we do have to make every effort. And I have been optimistic to see, since the loss of George Floyd's life, more than 2% people of color have been added to for-profit boards. It took 40 years for the same equivalent number of people of color to be added to for-profit boards before George Floyd's death. But now, in a matter of 8 months, 2% of people of color have been added to for-profit boards, which is where power lies and money lies. That's one indicator that I'm looking at and many others. But the point is, this is a little different. With so many feet on the street, we can't settle for small change. We need big bills and big action. And so, all right, on that note, that's a good closing. I want to thank you all for your time. Thank everybody for your presentation. I thank each of our experts, including Dr. Ritter, Dr. Carney, Dr. Ballou, Dr. Diggs. We appreciate you. I want to thank all of you leaders on the line, including even Dr. Boynton, I know, who got 85% of kids tested in a 99% African-American school district, and others are trying to as we speak. And if they don't, they got a test in the fall to do what Dr. Ritter said, and that is know what the learning loss or gain was. And so that's part of our preparation as we continue. First, know better so you can do better. And I thank you all for helping each of us know more so we can do better. Have a great evening. It's 5 on the dot here in St. Louis. Have a great day wherever you are, and we hope to see you soon.